My name is Ray Williamson, and I'm the PBC coordinator for British Columbia. I was diagnosed with PBC in 2010 and found PBC Canada shortly after my diagnosis, for which I am eternally grateful. I was an atypical patient and was referred to several specialists before finally being diagnosed. It was an interesting journey. My treatment began immediately, and with Ursidol, my numbers quickly returned to an almost normal range. Fortunately, they remained there over the ensuing years, allowing me to lead an unrestricted life into my retirement. As a resident of BC, I became aware of the increased prevalence of PBC amongst the First Nation community in Duncan. Being a curious person, I did some digging and found that Alaska also had reported increased numbers. Given it's quite often a challenge as a patient to explain PBC to others, I can't imagine the challenges that First Nations communities face in accessing a timely diagnosis and treatment. Because we don't know yet the cause of PBC, looking for patterns such as this may lead us to some answers. And continued research will have many positive benefits in building awareness among those involved in Native healthcare and the communities that are affected. It's my pleasure to introduce Dr. Andy Mason, who will share his insight on the prevalence of PBC amongst First Nations in Canada and worldwide.
I was just saying hello to Ray. Well, we learned a lot from Professor Hirschfield today, and I'd just like to tell you I'm phenomenal. Well, I've been working, I've had my sort of love affair with PBC for 50 years now. I just do a little bit of mathematics. So that's when I finished my finals at medical school. And I went into a cubicle in the exam, and I was confronted by a very nice lady, not unlike yourselves. And I said, "Madam, what's wrong with you?" She said, "I'm tired, I itch." And I go, "PBC," like this. So I passed with honours. You may wonder about the medical system in the UK, why we encourage doctors to study PBC and then send them to Canada. And it's because we've got this abnormal dopamine gene. You know about this. So this is why our prototype Africans left Africa all those many thousands of years ago. They got bored, and they're the ones that had different dopamine receptors, we found out. Anyway, so that's why Gideon and I are here. That's my excuse anyway. So here are my disclosures, but I want you to look at the bottom one. I've been using something called Midjourney. It's an artificial intelligence program to do my figures because, quite frankly, I just don't have the imagination. So what you do is you type in primary biliary cholangitis, and then you type in First Nations art, and this is what you see. So it's actually, these are much nicer than the pictures I showed yesterday, which were pretty, I mean, they couldn't really synthesize decent pictures from some of the things I asked them to. So this is the Midjourney, and there's lots of artificial intelligence programs that will do this kind of thing for you. So I'll show a couple more later, but this is the guy on the screen there was my award from CASL for being the first visiting professor in Canada, and it was painted by a resident in Calgary, and it's called The Spirit of the Liver, and I just think it's fantastic. It looks like there's a little frog in there. There's clearly some form of starfish. And I just do not know what's in the gallbladder, but it's green and mean. So my job today is to talk about a little bit about what Gideon spoke about. And we have different views on how PBC occurs, but we counterbalance each other. So you might hear different things from me than you hear from Gideon, but the truth is Much of this we just don't know. And if we did know, we would quite frankly do a better job, because we fail in many areas, especially with dealing with fatigue and other symptoms. I'll be talking about why PBC is increasing worldwide and why other autoimmune diseases are. And then we'll come back to this idea of ancestry and why things are worse for our Aboriginal Canadians and Aboriginal North Americans and probably South Americans as well. So about 20 years ago, you'd be faced with the figure on the left, where we thought genes combined with environment and immune regulation to cause autoimmune disease. But I don't know how helpful that is in deciding what causes the disease. And sometimes it's just much easier to look at this list. So on the list on the right, we've got some factors we call modifying factors. So if you drink alcohol, that can make your disease worse. So that modifies your disease. If you smoke cigarettes, it can make PBC worse. If you have the female sex, you are more predisposed to PBC, but clearly men get PBC as well. And we'll come on to race, sunshine, and other factors. I'm not really going to talk about the guys on the left. So we think that the microbiome or the composition in your gut will alter your response to any insult that may trigger PBC. Certainly people with PBC have more leaky guts, which has something to do with the microbiome content. And as Gideon said, we have 5 to 6% of our patients have celiac as well. There's some bacteria have been implicated in PBC. I myself work on a beta retrovirus that we found in PBC about 20 years ago. We have made diagnostic tests for this now with QIAGEN, and we are trying to get this out so we can diagnose the virus more easily. And we've done a few clinical trials by repurposing drugs. That means we've taken drugs from hepatitis B and HIV and used them for PBC patients. In our first studies, we saw a little bit of improvement. In our second study, we found really that 80% of people couldn't tolerate the medications, but the couple that could did very well, and their liver tests sort of came down to low levels. And we still have patients now who are on antivirals, especially those post-transplant who've got severe recurrent disease, and that's helping to maintain them. But that's certainly not mainstay therapy. So I think if we can find good repurposed drugs for this virus and show that they work, then that area will take off a bit more. Then there's the idea, as Gideon said, that xenobiotics or chemical compounds may trigger disease as well. And certainly there's this idea that genes do. So we're going to go, my task is to go around the world and discover and say what PBC is. So this is where I used to live about 20 years ago in Louisiana, actually, rather than in DC. Now, this is a quiz, so just shout out if you can answer this question. Gideon, you should know. Well, there are 3 presidents there, yes. Sorry? Well, it is genetic in part, yes. Well, they are. There's very little I can do about that. Well, so the family, okay. So the Kennedys had, they both got autoimmunity running in the family. So the Kennedys, Teddy had polyglandular autoimmune disease. So he had 3 autoimmune diseases, including Addison's and celiac thyroid disease. And then we think all the Bushes had, well, certainly George Sr. and Barbara, and Millie the dog had something as well, if I remember correctly. And so my buddy, Robert Gary in New Orleans, found a virus called HIAP. which stands for human intrasternal A-type particle. And he found that people with Sjogren's disease and with lupus made antibodies to this virus. And so he was very interested in seeing which patients had antibodies to his virus. And if you look on the right, I don't know how good your eyesight is, but I've got these wonderful glasses that vary when I go like this. So bottom right, it says Houston family, wife, lane A, husband, lane B. So that would be the top and the bottom of that photograph there. And they were both reactive to his HIAP virus, but they didn't have Millie the dog there. But Millie had some form of thyroid disease as well. So I think what Robert was trying to do was just show that there could be some viral episode going on with patients with autoimmunity. And this is how I started off actually. Once we found beta retrovirus in PBC patients, we used Bob Gary's retrovirus, the HIAP, and showed that most patients with PBC had antibody reactivity. So that's a little bit of frivolity for you. So PBC does run in families. So as Gideon said, the prevalence is about 1 in 3,000, but your first-degree relatives, it will be more common. And female first-degree relatives will have a 1 in 50 chance of having disease. So that's high, but it's not horrible. So we have to emphasize that to patients. Now, actually, Shauna, we've got, at the first time we met at that barbecue in Alberta, there was a husband and wife there that had disease. Now we've got a second one now. So we've got 2 husbands and wives in Alberta who have PBC. So the disease is found in related and in unrelated family members. So the unrelated family members are shared environment, and the related ones are shared genes and shared environment. So it's difficult to sit and work this out. This is called nature versus nurture, sorry. And so this is difficult to access. And you have to go elsewhere to do this kind of research. So you go to Scandinavia. So this is, now, does anyone know why you can do this research in Scandinavia? Well, they've got extremely good records. So in other words, this study I'm going to show you, this is a cancer study, but that's not the point. This study, what they did was look at families in Denmark, Norway, and Sweden, and they looked at twins that were identical who were brought up together and twins who were brought up separately. So they did that perfect study of people that had exactly the same genes that were either together or separated. And what you can see, if you could read it, is that, for example, cervical cancer, which we know is related to papillomavirus, is close to 0 for genetic factors and very high, 80% on the environmental factors. Whereas something like breast cancer, no, it's not me. I'm incapable of making noises like that. So breast cancer is about 30% genetic, and it is about 70% environmental. So the environment is twice as important as genes in breast cancer, for example. But as I say, you have to go to Bergen or to Oslo or somewhere like that to do that kind of study. So next we go to Sardinia to talk about genes and sex. So you say, why Sardinia? Well, there's something odd in Sardinia, but then there's often things odd about islands. So there is something called an ancestral haplotype, 8.1. And all that means they're a chunk of genes that they all get passed on together usually. So it's just a haplotype is many genes. So that's like it comes in a box. And if you have this and you're a female, you are at risk of getting all these autoimmune diseases, which is not good. Guess what happens if you're male? Oh, no, nothing. You live till you're 90. So this is some sort of genetic joke somehow. And actually what this haplotype does is it just makes you slightly less responsive to viruses. And so women, as they go through pregnancy, for example, have increased immune suppression, and maybe they don't respond as well to viruses, and then that tips them over. And we know there's something about lack of immunity and the development of autoimmunity. So, for example, when your immune system is very low, you start making more autoantibodies. And this is something that's sort of well studied. So, a little bit about sex. Oh dear, that came up 3 times. Does anyone know where this is? So this is where the phenomenal Dr. Hirschfield published this polygenic study, the Cross Canada study, and this was a really wonderful study because it tells us that this one area, you can see all the dots in the middle, this is called a Manhattan plot, but all those dots in the middle tell you what your risks are. And where it says HLA-DRB8, that is the highest risk for developing PBC, is that gene, which is actually quite rare in Europeans. So, but it tells you all these other genes, the lower dots, they still give you a higher risk of PBC if you're born with those specific alleles. So we know that many genes contribute to PBC, but the odd thing is, when you go to other areas of the world, like Japan, for example, it's a different set of genes that predispose to PBC, but that HLA-BR8 is still there. And the same for other parts of the world. Oh, we're in Barcelona now. That's La Sagrada. So sunshine makes a huge difference. And so if you are in the UK, which sees approximately 2.8 minutes of sun per year, you just don't get enough vitamin D, and that's why all the Brits come to Canada. But if you truly, as you move further south, you actually see a diminished frequency of autoimmune diseases and a decrease in fatigue. And I don't know whether the warm makes you more frisky or whatever, but certainly the vitamin D helps you. So if you can't get out in the sun, pop some pills. Oh, here you go. So this is what, when you put in primary biliary cholangitis in the style of Pixar, I apologize, what can I say? I don't know why one eye featured, but clearly that's what Pixar thought was the appropriate. It looks like the one on the right has got some form of medication there, but looks very happy. So what's happening with the autoimmunity worldwide? So the idea is that, well, certainly, if you look at these graphs, we've got a bunch of diseases that were clearly mediated by infection getting more scarce. Then on the right, you've got these autoimmune diseases that are becoming more frequent. And so the author of this paper came up with the hygiene hypothesis, which is a real thing. So the hygiene hypothesis is we've gotten so clean now that we don't educate our immune system properly. And then for some reason, autoimmunity occurs. It's got the immune system's got nothing to do, so it starts fighting itself, which is a little bit odd. But there's something that we've really seen following COVID, where all these kids have been isolated. We've started seeing these nasty attacks of common viral infections, such as adeno-associated virus, causing liver failure, not just in the UK, but in North America as well. So this idea is that these kids aren't getting infected with harmless viruses that educate their immune system. And then when something a little bit more harmful comes along, they don't know how to deal with it. Now, there is an alternative hypothesis here, which is that possibly all those diseases, multiple sclerosis, Crohn's disease, type 1 diabetes, and asthma, possibly they're all infectious, and the infectious agent is just getting a little bit more common as other agents are becoming less common. We don't know. But we do know that PBC is increasing worldwide. And we used to have these discussions about, maybe our diagnostics are getting better, or maybe people are more aware of PBC, but I mean, the truth is that the disease is becoming more common. And we used to think that PBC was rare in China and Japan, but we're seeing some very, very high prevalence rates there now. And there are data to suggest that PBC is actually more severe disease in southern Asia. So people get worse disease and they have a higher prevalence. So again, we don't know why. So now we turn to Canada. And when we look at PBC by province, I found this a bit odd. I was thinking to myself, well, Alberta's strong, we got a lot here. BC, we got our, First Nations who have really high rates. And then it turns out that the maritime provinces have the highest rate. And you go, Jiminy cricket. So then when you look at this, now when I was at med school, I learned that PBC was a middle-class disease. As I told Shauna, tired, well-educated women. But the truth is that the prevalence is highest in areas that are less desirable. So in the UK, it's close to coal mines. In the US, it's close to Superfund sites, which are these large toxic dumps. We know the disease is most aggressive in the US, in the Midwest has been reported, which is, again, a bit odd, but certainly in the Midwest there are cases of a higher prevalence and more progressive disease. And then there's this issue with the First Nations, which is really poorly understood. So we have probably a 10-fold increase of disease in coastal First Nations, just the back of the envelope calculation. So I've been to Duncan and taught there and been around the island. And really, in some practices, the prevalence is probably as high as 1 in 100 to 1 in 200 people, which is just shocking. So we go to Vancouver Island, and so you remember back to Gideon's family tree he showed of a gene that was in probably half to 1 in 4 people. Here, this is a family at First Nations where if you look at the colored versus non-colored circles and squares, you will see that the PBC almost behaved like what we call an autosomal disease, like a one-gene disease, where you have 1 or 2 genes that dictate disease. So in this family, published by Laura Arbour about nearly close to 20 years ago, we've got about 1 in 4 people with PBC in this one family. So that's really high prevalence. And then Eric Yoshida, who was running the transplant program in Vancouver, reported that if you are First Nations, your chance of being transplanted for PBC was over 50%. So of all the transplants, First Nations, over 50% were PBC. Then if you look at the other patients transplanted, only 16% were transplanted for PBC. Then if you keep going around the circle, you see the other quarter of patients were transplanted for autoimmune hepatitis. So you've got over three-fourths or 75% of First Nations are being transplanted for autoimmune liver disease. So this is something that we have studied in our Canadian network of autoimmune liver disease. These are all the groups that are involved across Canada. And I run the western side and Gideon runs the eastern side. And we have over, how many patients now? Is it, Gideon, like 5,000 registered? And so this study here was with 2,300 PBC patients. And Gideon showed this slide earlier. And I've only got the one slide on this now. But you can clearly see in green that the liver transplant survival for patients who are Indigenous is at 50% just at 10 years. That's their survival. Whereas for our other PBC patients, it's around 80 to 90%. Now, I don't have all the data here, but if you look in light blue, that's our South Asian patients. And if you look at other liver tests, you'll see that they're worse for the South Asian patients if you study them separately, and they're the lowest of the other group, but certainly not as bad as the Indigenous. Then the other thing that we found was that symptoms were much worse in our Indigenous Canadians. So a higher score is worse disease. And you see on your right-hand side, all the green scores for First Nations are worse for fatigue, worse for clinical symptoms, worse for emotional score, worse for cognitive scores. So the First Nations clearly had worse disease across the country. And we asked why patients have worse disease. Do they present later? Do they have diminished access to healthcare? Do they have decreased compliance with medications? And we can't answer those questions. We're just doing a survey here. But the important thing is that we know that Aboriginal North Americans have a higher prevalence of lupus, rheumatoid arthritis, and multiple sclerosis. And they also have other illnesses that are autoimmune, like vasculitis as well. And this is in Alaska, in the Midwest of the US. And we heard yesterday from Dr. Levy that Hispanics have worse itching in the US. So we don't know about South America, but I suspect that all of Mesoamerica has these higher prevalence of autoimmune diseases. So we've talked about the worldwide prevalence of PBC. So our First Nations are 1 in 200, but there's also a very high prevalence in China as well. And then we want to look at this one gene, the DRB8, and I want to make the suggestion that having this gene makes it more likely that you get primary biliary cholangitis. So if you look in Europe, this gene is present in 4 to 10% of Europeans, so it's fairly low. Then in the Far East, it's 15 to 20%, and then if you look in Africa, it's really high, it's 20 to 40%. So when our ancestors marched out of Africa and then over the Bering Straits into America, this happened about 10,000 years ago. And then the land bridge closed, and following that, the the North Americans were not exposed to European risk factors for disease until the 14th, 15th, 16th century, when the Europeans started coming over and infecting them. And the thing is that the Dene and the Cree have got a very, very high prevalence of this one gene that is the highest risk factor for PBC. So my thought is that the Europeans came over and then infected them with whatever causes PBC or these other autoimmune diseases, and that's a possible trigger. It's just a conjecture, but we'll have to wait to see what the causal factors are. So we're finishing up now. So there is an increasing prevalence of PBC in Canada, and it's much higher in our Indigenous communities, which is something that we need to deal with. There's an increasing prevalence of PBC worldwide. And my thought is that there may be increasing infections causing this disease. And if you're interested in finding out more about the human beta retrovirus that we've linked with PBC, you can just do a search, and I have a viruses special issue that's just on human beta retrovirus and related disease that you can look at. And thank you very much for your attention.